Good morning, good afternoon. Thank you everyone for joining us today on webinar for spinal tuberculosis overview and early detection. This is Imran. This webinar has been jointly organized by University of Stellenbosch and University Research Co LLC, URC. This webinar will be presented by Dr. Jacques Lloyd, Director at Afrique Rehabilitation and Research Consultant, NPC. Marisa Coetzee, Senior Research Assistant at the Department of Health and Rehabilitation Services, Stellenbosch University, South Africa. Dr. Sjan-Mari van Niekerk, Researcher, Stellenbosch University, South Africa. So I'm going to hand over to Dr. Jacques Lloyd or Marisa, who will start.
Thank you very much for the introduction. I am very excited about the online course. Just a little bit of background on where this comes from. I'm also a person with a disability in a wheelchair, and I've been working in the field with people with spinal injuries. And in South Africa and other countries that I've worked with in Africa, Uganda, Tanzania, Sudan, and Malawi, we have come across a lot of people with spinal cord injuries. And the challenge that I found was that most of these people were diagnosed at a late stage, and that brought up the question that why are we not looking at guidelines for early identification to prevent this terrible impact that spinal TB has on the lifestyle and the physical challenges that people develop as a result of secondary complications. And I am very happy that we could take hands to put together this short course. And I'm going to give over to Marisa to continue and deliver that.
Thank you, Jacques. All right, so I just want to see.
Okay, let me change the control to.
Thank you.
Okay. Okay. Yes.
Thank you.
I think it will take a second.
Yeah. Okay. No, that's good. It says I'm controlling the screen. Now All right.
Yeah,
Okay. Yes, I have control now. Thank you. So good afternoon. My name is Marisa Coetzee. I'm a senior research assistant at Stellenbosch University, like Imran said. And I was very fortunate to be a part of this project with my colleagues, and one of my colleagues are sitting here with me today. So we'll take you through the course, or just a brief overview, basically, of what spinal TB is, the recap of the most important aspects, and then Dr. van Niekerk will talk about the spinal TB review that we did, the development of the clinical decision-making algorithm, which we developed to assist anybody working in primary healthcare to pick up spinal TB early on. And then we'll have two quick cases to demonstrate the use of the tool, and we'll talk about the publication that we put out last year. All right, so this is a very nice and telling picture. It was taken in the Eastern Cape by one of the co-authors on the paper and the project, Sandy Conradi. The one little boy, the one that you see in closest to you, there was no issues with him. He was fine, and then we came to the clinic and he was paralyzed at some point, and they didn't detect the spinal TB early. So he was diagnosed with spinal TB, and he had to get a wheelchair now. And the poor child was not very keen on the use of the wheelchair. He was very shy, and he was isolating himself because of it. So they decided to bring in the other little kid that was born with spina bifida. So he's been in the wheelchair his entire life, and they introduced the two, and he showed him how to use the wheelchair, and suddenly this kid's life was looking so much more promising than before, with the use of the wheelchair and his new little friend. So yeah, this is what clinicians are dealing with on a daily basis in our rural healthcare settings especially. So yes, why do we need to talk about spinal TB? So spinal TB is the most common form of extrapulmonary TB, and a re-emergence of TB is currently seen due to the increase in HIV prevalence and the development of drug resistance. In developing countries, TB is the most prevalent HIV-related opportunistic disease at 54%. So spinal TB leads to high levels of disability and sometimes even death. So because of the insidious nature of the disease, clinical diagnosis is mostly always delayed. So the disease progression could occur without symptoms, and patients are often seen by clinicians when neuromotor complications have already set in. So the patients then have poorer outcomes. So to address the challenge, a multidisciplinary team of researchers and clinical experts consisting of physiotherapists, an orthopedic surgeon, physicians, and a primary healthcare nurse at Stellenbosch University developed a best practice model based on the available scientific evidence and clinical expertise. The program also provides a user-friendly clinical decision-making pathway for screening and for early diagnosis. So this training is aimed to benefit any primary healthcare practitioner, any medical officer, physiotherapist, anybody, but especially the nurses at primary healthcare, because they are the primary contact or the first contact for these patients most of the time. So we want to make them aware of the things that they need to look out for early on to diagnose this. So our early detection and early diagnosis challenges in Africa, it is mostly impeded by the lack of resources that we have at primary healthcare level. And I'm talking also specifically about the more rural areas. They don't have MRI machines and other investigative equipment. There's a lack of knowledge from the community as well as the primary healthcare staff. They have poor access to transport for clinic visits. So as you can see in the pictures here, this is also in the Eastern Cape. It's not, traveling to the clinic is not on a road that's easily accessible for someone with a disability. And they pay a really, really big amount of money to get transport that can take them from their house to their clinic. And then also there's poor compliance to treatment for TB, unfortunately, as well. So yeah, let's see. So the pathophysiology. TB causes necrosis of the affected tissue through granular inflammation via lymphocytes, resulting in a cold abscess formation. Spinal tuberculosis is always secondary from a primary site, usually in the lungs, the lymph glands, the gastrointestinal or the urogenital system in adults. However, in children and adolescents, the disc is most of the time the primary origin because it is more vascularized than in adults. So during the development of the infection, it can move up or down the vertebral column. It's more commonly seen in the upper lumbar and lower thoracic spinal segments, especially the thoracolumbar junction. And more than one vertebra is typically affected, resulting in deformity. So the spread to the spine is through the blood vessels into the dense vasculature of the spinal vertebral bodies, the anterior inferior section mostly, to the rest of the vertebral body and the disc, and then to the anterior and posterior longitudinal ligaments, which gives support, and adjacent vertebrae, resulting in destruction of the intervertebral disc, collapse of the spinal segments, and anterior wedging. And then eventually you can have subluxation and dislocation because the stability of the spine is compromised. So 5 key components were identified for early diagnosis of spinal TB. Firstly, an associated factor assessment should be done, and then also an assessment for common signs and symptoms of spinal TB. You need to flag significant clinical findings upon a physical assessment. flag significant neurological or neuroradiological findings, and then flag significant laboratory findings. Associated factors, these are, spinal TB is highly prevalent in people with impaired immune systems, so people with HIV, previous or current pulmonary TB, or exposure to pulmonary TB by family members that's living with them, or an individual living in a TB prevalent country, malnutrition, alcoholism, drug abuse, smoking, diabetes, chemotherapy for cancer, and individuals with back pain under the age of 20 or over the age of 50 is obviously also needs to be investigated. So the clinical presentation, so if we look at the symptoms, the presentation of the symptoms is extremely varied, and that's why it's very difficult to pinpoint this early. The average duration of any symptom until seeking help or diagnosis is usually 3 to 4 months. And it is important, therefore, for the clinician to obtain a thorough history and identify the symptoms and associated factors that is indicative of spinal TB. So if we look at back pain, which is usually the earliest and most common symptom, followed by fever, weight loss, and neurological complaints, the common characteristic surrounding the back pain is that it should be, it usually is insidious, so gradual and subtle. There's no incident that they can relate to their back pain. They didn't pick up something a week or a month ago or fall or something. They just don't know. It started out of nowhere and it gradually increased. And then the nature obviously is not mechanical, and then pain is mostly localized to the site of involvement. So the patient can actually point to the area of pain with one finger instead of saying with the whole hand, it's in this area. It's usually quite specific. And then neurological complications are more common in patients with an epidural abscess. So if it is left untreated, early neurological involvement may progress to complete para or tetraplegia. So paraplegia may occur at any time and during any stage of the vertebral disease. There can be early onset paraplegia, which develops in the active stages of spinal TB, and that requires active treatment. However, there can also be late onset paraplegia, which could develop 2 to 3 decades after the active stage of the disease. And that's usually associated with the noticeable spinal deformities. In South Africa, unfortunately, almost every second person with spinal TB presents with paresis or paraplegia when they attend their primary healthcare facility for the first time. So that's why we want to pick up these symptoms early on so that it doesn't lead to paraplegia. And then the third symptoms that you should look at is the constitutional problems. It's the same constitutional problems typically associated with pulmonary TB, which is fever, weight loss, night sweats, coughing. But weight loss and fever is the most common that is found for these patients. All right. So when we look at the clinical presentation, unfortunately, there's not a single test that you can do for spinal TB. Diagnostic tests helps you with the clinical reasoning and differentiating between other possible causes. But we do recommend that you look for any signs of spinal deformity or a cold abscess, perhaps. Feel for spinal tenderness on palpation, pain with percussion on the spine. Measure muscle strength if you have a suspicion that neurological weakness might have already started. And then ask the patient to move. They should, I'll take you through that now, but they should bend and maybe cough as well to see if that elicits the pain. So the cold abscess, as you can see there in the picture below, it can be anywhere, but it's usually associated with the area that is affected. So especially in the cervical spine, you might find it retropharyngeal or anterior posterior triangle of the neck, maybe in the axilla. The patient might present with pressure that causes dysphagia, hoarseness of the voice. So be on the lookout for that, but otherwise it can be in the lumbar spine, also all the way down to the groin. Yeah. So if we move on, if you ask your patient, this is part of the neurological screening. So you've assessed the patient now, you touched, you looked, and you felt what's going on around the spine. If there's maybe a muscle spasm around that area, particularly tender in one or two spinal segments. But you should also conduct a neurological screening just to make sure that there's not maybe weakness that patient doesn't even know about. So they can't tell you about the weakness because they're not even aware of it. So ask your patient to stand up from the chair and sit down, and look for difficulties getting up, poor control when sitting down, or the need for using the armrests for assistance. And also, if they complain of upper thoracic and neck area pain, ask them to grip your hands. Look for weakness in the hand grip or a difference between the left or the right hand side. And then this is also a very nice one, a single leg heel raise. Ask the patient to stand on the one leg. They are allowed to hold onto the bed because it's not a balancing test. And then you ask them to lift the heel. So if they are have difficulty maintaining balance, even though they are holding on, or if they have difficulty lifting the heel off the floor, or if there's a difference between the left and the right leg, you should flag this. And then you can ask them to just walk up and down in your room or in the corridor, and look for some signs of deviations in the walking pattern. So uneven weight distribution, or a wide base of support, so the feet are wide apart, a limping that's not related to any previous medical history, any balancing difficulties, or if they need walking aids, poor control of the hip or the knee or the ankle, or if they are walking slow. These can all be signs of some neurological deficit that has set in. Right, so we do have some recommendations for special tests for a spine that's under observation. So firstly, a sputum test. For 14 to 37% of people with spinal TB is co-infected with pulmonary TB, so that's a good test to start off with. A positive test indicates for TB treatment and, of course, further examination. And then also the recommendation for HIV testings, CD4 counts and viral loads, as these individuals can have an increased risk for immune reconstitution and inflammatory syndrome. And you should also know the start of the ARV treatment date, or if there's been any regime change recently, and then also the CD4 and viral load counts. And then we said the erythrocyte sedimentation rate, the C-reactive protein and platelet count should be looked at, as it could be a diagnostic clue, as well as the white cell count, hemoglobin, and alkaline phosphatase. But it should be noted that a normal WCC and anemic presentation is typical in spinal TB, and an elevated alkaline phosphatase may indicate spinal TB. And then, to the next slide. And then also you can do a MAN2 TB skin test, however, in a HIV or a TB prevalent country such as South Africa, it's not very useful because it can be affected by HIV and other immunosuppressive conditions, and you could get a false negative. So that is not really indicative. And then education. All spinal TB suspect patients should receive education to monitor and report their own symptoms. So they should take note of pain severity and behavior, neurological presentations such as loss of sensation or muscle weakness or even pins and needles. If there's a decrease in function, balance, and or gait, if there's any new onset of constitutional symptoms or new onset of swelling. So these are very important points for the patient to look out for in their own capacity at home. So when we look at management, conservatively, we can supply the patients with orthosis for thoracolumbar support. You can get that from the physio, and then dietary support, especially for the malnourished patients, and then physiotherapy and occupational therapy to address the functional and neurological problems, and improvement of general hygiene is highly recommended. and then of course psychosocial support. When we look at chemotherapy, this constitutes the treatments of using drugs. Standard drug regimes typically consist of a quadruple combination of drugs where they give an intensive program for 2 months, followed by a combination of rifampicin and isoniazid for 6, 9, 12 for 18 months. So to achieve bactericidal and sterilization effects, multi-drug therapy is used. And in South Africa, to optimize the compliance, we have the directly observed treatment short course, the DOT system. We have Rifafor, which is a combination of the 4 drugs in 1 tablet. And then the patient also receives financial grant for the duration of the treatment to incentivize and improve their well-being. And then surgery, when the patient has severe pain and spinal instability, this is usually during the advanced stage, surgery is performed. If you do find that your patient has neurological symptoms, you should refer them as soon as possible. So this is done when spinal instability and of the anterior and posterior column is involved, and they do a decompression and debridement, and usually a vertebral fusion for these patients. So you'll see on our next slide, this is the tool that we've developed. My colleague will now take you through this tool, exactly explain to you what is going on in each of the boxes and how it is used. So I'm going to hand over to Dr. Sjan-Mari van Niekerk.
Good day. So I will be talking about the spinal TB review that we did in preparation for developing the decision-making tool. So the team at Stellenbosch University did a comprehensive literature search, and this was conducted from October 2018 up until March 2019. So we performed the searches in various of the search engines, PubMed, Scopus, Google Scholar, and we used specific mesh terms and combinations of terms relating to TB and spinal TB specifically. So the eligibility criteria of the papers that we included was that the papers had to be published between 2008 and January 2019. It included case studies, so N=1 studies, as well as case series, which were then handled as a single case study. And all of these had to report on the risk factors, clinical signs, symptoms, diagnostic investigations, and the standard management of spinal TB. For data extraction, we extracted data on age, gender, the nationality of these patients. We also extracted the clinical signs, symptoms, the risk profiles, investigations that was done, as well as the treatment that these patients received. We did a critical appraisal of each of the papers that were included, and they all scored good on the scales that we used and was thus included in our study. For data synthesis, we use a narrative review and descriptive analytical methods to summarize the data, and this was followed by factor analysis to simplify the clinical presentation patterns which may present as unmeasured variables. So designing the clinical decision-making algorithm, we used various steps, and we will discuss the 5 steps right now. So the first step was defining the content for the tool. So upon completion of the factor analysis and the evidence framework during the first part of the review, they identified 14 associated factors. The symptoms, the physical signs, and investigations formed the basis for the clinical tool. And since many of the cases included in this review presented at secondary and tertiary care level, we had to extrapolate the relevance of the important information to the primary care level, as this is where our focus lies. So step 2 was adding context-specific information that was not reported in the case studies. Just to mention, in total, we included 28 case studies. And after identifying the relevant content from the case studies, the knowledge gaps were found, which were particularly pertinent to our local context in South Africa and Africa specifically. And for instance, at primary care clinics, we deemed it important that suspicion of all patients with back pain, irrespective of the likely cause, be referred for gene expert sputum analysis. And considering the significant burden of STB and its potential severe disabling and costing effects of STB, it is deemed a high-value, low-cost strategy with no harmful effects. And due to the high burden of HIV and TB in South Africa, patient education and case monitoring of significant importance. And this was not included or featured in any of the case studies that we found. And therefore, the review team added these as elements in our decision-making protocol. Step 4 was consulting the experts. The tool was then evaluated by 2 practitioners at primary care level. It was a family physician as well as a registered nurse, and their comments and suggestions were incorporated into the clinical utility of the evidence guidance tool. So this is what the tool looks like. There's quite a few decisions that needs to be made down this road, but what we've decided and mentioned previously is that every patient with neck, thoracic or low back pain should be asked the various questions as they are all suspect to spinal TB. So you will see we also refer to certain boxes, like in the first box we say C box A. These boxes with extra information has been included at the end of the slide, so you can refer back to those when you do go through this clinical tool. So we say the first thing that you would ask a patient that does present at primary healthcare level with any of the neck, thoracic or back pain symptoms, you would ask them what is the history and the nature of your pain. And as Marisa has mentioned, the thing that would stand out for you is if there's an insidious onset of pain, but also we cannot exclude anybody with a traumatic back injury because TB and spinal TB is quite prevalent in our communities. So when you do have somebody presenting with pain, the first thing that you would ask them is to assess whether they have constitutional symptoms. So those are the coughing, sweat, night sweats, fever, a decrease in appetite. When they then say no, whether it was insidious or a traumatic injury, you would refer them to the physio for conservative management. And here it is very important to educate your patient on what to monitor themselves for. So if there is an improvement over the 6 weeks, which you would expect, that is wonderful, but you need to get your patient to understand if there's any changes in their conditions, they need to report back to you immediately. And the things that you would want them to monitor is if there's a change or an increase in any of the following symptoms: pain or severity of the behavior of pain, neurological conditions, such as a loss of sensation, muscle weakness, pins or needles, if there's a decrease in their function, their balance or their gait, or if there's a new onset on constitutional symptoms, or there's a new onset of swelling. So it's very important that your patient then refer back to you if any of these are present. So if there's no improvement after the 6 weeks of conservative physiotherapy treatment, you would then perform investigations. So you would then ask for a sputum sample at primary healthcare level, or you would refer them for x-rays if they are available. If any of these comes back positive, you would then prescribe TB treatment and monitor the patient. So if we go back, if you say that we have done the sputum investigations or an x-ray and the test came back negative, you would then have a suspect patient with no associated factors and or no physical signs. So again, you would educate this patient on the aspects that I mentioned before. So if there's any changes, they need to refer back to you. And you would perhaps consult a colleague for a second opinion. Then if you have a patient, again, with either insidious or traumatic, but most likely insidious onset, and they say yes to any of the constitutional symptoms that you've asked them about, you would then assess if any factors associated with TB spine is present. And for these, you can look in box D that is provided below. So these would be whether there's an associated HIV infection. You would also have to ask them about previous ARV history, if they are malnourished, if they've been exposed to TB, if they have previous pulmonary TB or current pulmonary TB, whether they're younger than 20 or older than 50 years of age, if they smoke or they use alcohol regularly, if they are immunocompromised, so they either have diabetes mellitus or they're on cancer treatment, and whether they are living in poverty. So if they say yes to this, this is where you would do a physical assessment that was described by Marisa to identify at least one of the associated signs with spinal TB. If they say yes, or you find any of these physical assessment positive, you would then conduct a neurological screening, which was also discussed by Marisa. If this comes out positive, you would immediately refer to a doctor for surgical evaluation, and this is quite urgent. Then if they've said yes to any of the constitutional symptoms, but there's no associated factors, or there's no physical assessments that was positive, or the neurological screening was negative, you would also then refer this patient to perform special investigations. So either sputum or an X-ray, because they have answered yes to the constitutional symptoms. So they would still be suspect of a TB. And then again, if that is positive, you would prescribe treatment for TB and monitor the patient. So the one thing that is really important here to note is that all patients with back pain should be suspect for spinal TB at primary healthcare level, because spinal TB presents in a highly variable manner, and therefore a comprehensive assessment is required to identify the full clinical picture. So now we're going to look at two different cases and see if you would be able to identify what the next steps of questions would be for this specific patient. So first we have a 46-year-old female, a new onset lower back pain for about a month, and it's slowly increasing in severity. There was no specific incident that she can remember related to the start of the pain. This patient is married with 4 children between the ages of 10 and 4, and her husband works in the mines in Gauteng, and she is now unable to do her housework due to the pain. So her children are attending school and are too young to assist her with housework. So quite a few cues in this case already. So the first thing that you would say, so she has back pain, so you would already be suspicious of what's happening there. So the nature of her pain is insidious. There's no specific event that took place. So she can't exactly remember when it started. So you would then immediately ask her, the next question would be to assess if she has constitutional symptoms or not. This is what you would ask then. And then, in fact, she does report that she does have HIV. She's positive. She is on ARVs, but not always available. They are not always available at the clinic. And she has no other comorbidities. And as we know, she lives in Gauteng, or she lives in South Africa, which is already a TB prevalent country. So what will you assess next? So you do the physical assessment, and she is able to point exactly with the finger to the lower lumbar spine to show where the pain is. And upon the physical exam, she also had tenderness around the lower spine with palpation, and she struggled to bend forward and touch her knees. So she is very specific about where the pain is, and upon movement, she had pain as well. So you would move on to the next assessment, which is your neurological assessment. So she is able to stand up and sit down in the chair in a controlled manner, and she could perform a left and right heel raise. Her hand grips were satisfactory for her age, with no discrepancy between left and right, and when she was asked to walk down the corridor, no abnormalities were detected. So where would she go next in this algorithm? So seeing that she said no to the neurological, or there were no neurological signs of concern, you would then perform an investigation and see whether she tests positive on sputum. So the results of the sputum sample you took came back, and it was positive. And she is then prescribed treatment for TB, and most importantly, monitored after this. So for case number 2, we have a 65-year-old male with back pain since 3 months ago. He has not had any previous problems with his back pain, but he noticed the back pain after he fell while fixing his vegetable garden's fence. So he lives with his wife and 3 grandchildren, and both him and his wife receive pension and child support grants for 2 of these children. His wife was diagnosed with pulmonary TB 6 months ago and has been adhering to her treatment. So he has traumatic back pain. And what would be the first thing you do for all of these patients presenting with back pain, as you ask about the constitutional symptoms? So he has been exposed to TB, but currently he is not showing any of the constitutional symptoms. So you would go towards the right of this algorithm and refer to a physio for conservative management. But as we said previously, most importantly, you have to educate him on the signs and symptoms to look out for, and if there's any changes in these, to then report back to you as soon as possible. So the physio picked up that there were no other danger signs, and they treated him for back pain, educated him, and sent him home with exercises and a follow-up appointment. Again, the follow-up is very important to see whether or not he has improved over the 6 weeks or not, and then to take care of him afterwards. Okay, these are the boxes that are referred to in the algorithm, so if you need to go through them in more detail, you're welcome to. this is a paper that we have published where we have spoken about the systematic review process as well as how we came up with the evidence-based clinical guidelines tool. So if any of you would need any more information on this paper, you're welcome to have a look at this or ask us any questions via email after this webinar. Thank you very much.
Thank you. So are you taking any question from the...
Has anyone else joined?
I can see that there is two typed questions, so we can maybe just look at that.
We have two questions.
Yeah. Anyone want to answer those questions?
All right, so we'll, instead of typing the answer, we'll just, so I don't know, can you guys read the questions as well?
Yes.
Okay, so we don't have to read them out loud.
So thank you for these questions. So on the first one, with the clinical observation on raising up the knee and walking, it is true. It can show, or it is tests that we use in normal physical assessments for patients as well. But if you remember, if you go down the algorithm, there's quite a few things that you've asked before that. So this is a patient that has already indicated that they might have constitutional symptoms as well, and they have been exposed to TB or they have shown any of the associated risk factors. So the algorithm cannot exclusively tell you, or the test that we've included here is not exclusively to diagnose spinal TB, but it is to increase the awareness of the possibility or to identify a patient as early as possible. So it is there to highlight a patient that might have fallen through the cracks before, that it can now access the right assessments in case it is needed.
And also, sciatica may present with more referred symptoms as well. So very specifically, spinal TB will be in one or two spinal segments, and the patient will be able to point with their finger to that segment without having referred symptoms. So obviously, if you do pick up that this is, that you can both refer them for physio or have sciatica as a query, but it is important to not just only consider that, but also look at TB. So X-rays can actually be done even if the patient doesn't have constitutional signs. So we don't actually recommend having X-rays for first-line treatment, and for back pain, the guidelines actually state that you should not refer for X-ray. We don't have X-ray at the primary healthcare clinic, so that is why we developed a tool to allow the healthcare practitioners, and especially the primary healthcare nurses, to just ask the right questions and look at the physical obvious signs that they might see. But it is possible to refer them for an X-ray. It's not that you are not allowed to. It's not typically done here because we don't have access and all the rural clinics. And also, if they don't have constitutional symptoms, but you are still worried, there might be a reason why you are worried, and then it might be indicated to do it. But it's not
it's not routinely done.
Yeah, it's not routinely
even just your normal back pain.
Yeah, I think from my side, I agree with what you said there. From experiencing the challenges in the field when it comes to being confronted with someone complaining about back pain and those type of things, I think the guidelines that we've set out is very specific in doing an early identification and making sure that you pick up on the detailed feedback from the patient, and then after that do a further assessment in going towards taking x-rays and those type of things. But as you said, those facilities are not that available in South Africa and even more in Africa. So I think that and we also do want in future for community health workers and lesser educated health workers to also be able to use the tool and to do the early identification. Yeah.
Yes. And there's another question, why are those aged under 20 at risk? So it's not that they are at risk, it's just if they come into your office and they are under the age of 20 and they have back pain, you should be very suspicious, especially if it wasn't related to a soccer playing incident with their friends or if they fell out of a tree. If they come in with insidious back pain and they're under the age of 20, you should be very suspicious. So it's not that they're at risk, it's usually associated if you're under the age of 20 or over the age of 50 and you have back pain, that they should be very suspicious and do further tests.
Okay, thank you. Any more question? I think we do not have any question. So thank you very much, everyone, for joining today. The recording of the webinar will be available on tb.academy. And we'd like to invite you again on the second session of this webinar on 23rd of March. Probably I'll send another reminder email for the second session of the webinar. So thank you very much.
All right. Thank you, guys.
Thank you very much.
Thank you. Bye.
Goodbye. Marisa?